Thank you, Chair. Good morning, colleagues, and thank you, Prof. Salim, for very direct to the point presentation. Colleagues, I will talk to you briefly about international guidelines and local guidelines for COVID vaccination, and then I will also get a little bit more into the Zambian scene to see how we've done with vaccinations, and give a bit of research from Zambia concerning COVID-19 vaccinations. So I want to already say that I have declared no conflict to this presentation, and I will move right through it. I think we don't need to belabor this point that vaccines are among the most effective tools we have in our public health toolbox, and vaccines have reduced and in some cases eliminated instances of diseases, and with vaccines, really deadliest diseases like smallpox are behind us, and vaccines save lives and they reduce the burden on the health system. Quickly into the WHO Strategic Advisory Group recommendations on COVID vaccination, and I think there was some questions around this. I hope that we'll answer them in this presentation. Broadly, they categorize individuals who've never received COVID-19 vaccination before, and those that have previously received COVID-19 vaccinations. And then the targeted population really are recommended for all adults, and then children and adolescents with comorbidities, health workers with direct patient contact, pregnant persons, and also individuals who are immunocompromised. So special attention have to be taken care of to those ones in yellow. For people who have previously received at least one dose of a COVID vaccination, I think it's to pay attention to those above 75 and adults above 50 with comorbidities, and also adults over 50, generally who are over 50 years, categorized as older age groups. So basically the recommendation is that you need to receive at least one dose and then a second dose. For people in those special categories, 6 to 12 months later, you require to receive additional doses. And I think those additional doses, the number of them really based on local existing recommendations, but also in consultation with your physicians who are attending to you. The CDC, from the US CDC, make also very clear recommendations, except that on their recommendations, they go down to age groups from 5 years to 11 years, and then those that are 12 and above, and then also recommendations for children 6 months to 4 months, and then people who are moderately or severely immunocompromised by various conditions. And they give specific recommendations for those who've never been vaccinated before and those who've been vaccinated. But I think the important thing about US recommendation is that a specific cutoff point for the first generation of vaccines are up, those who received them by up to 11th September of 2023, and then newer updated sort of refined formulations of the vaccines for those getting beyond September 12th, 2023. I will very quickly get into the Zambian situation and to basically say that in Zambia we've had a basket of at least 5 vaccines, starting with the Pfizer, Moderna, AstraZeneca, Sinopharm, and Johnson & Johnson. And these have been adapted based on the recommendations from the manufacturer and based on literature that have been used. So in Zambia, we began really with vaccinating adults from 18 and above, and later we reduced the age to children from 12 to 18, and those are only given the Pfizer-BioNTech vaccine, for which the local Vaccine Immunization Technical Advisory Group from the Ministry of Health recommend that would be appropriate for use. And so children 12 to 18 will eligible to receive the Pfizer vaccine, and those 18 and above will receive any of the vaccines as listed on this slide. So since about April, May of 2021 began the vaccination program with COVID-19 in Zambia, and I think the long story cut, we had a lot of challenges taking off the vaccine program, and as we began to overcome those myths and misconceptions, we then ramped up the vaccination program. Really, by the time we were getting to the 2022 mark, the provinces, the 10 provinces of Zambia had begun to hit the targeted 70% national coverage of eligible population. And this slide just summarizes the various achievements in coverage by the provinces. And that speaks of the same thing, but in a pictorial form, comparing the performance 2021, 2022, into 23, and the current situation. Basically, I think that the differences in the intensity of the color speaks to the progression with the volume of vaccines that have been given. These slides break down the vaccine coverage into the various age groups. The first two bars refers to those children between 12 and 17, those that received a single dose and those that have received at least 2 doses. And then the next is those aged between 18 and 59. And the last 2 bars refer to those above 60. So consistently, we've achieved better coverage with a single dose, and the performance with 2 or more doses has been quite a struggle, and I think you've seen from other presentations this affirmation. So the question was always for us, is there any local evidence concerning the safety, concerning the immunogenicity and the effectiveness of these vaccines? So as we got into these programs for COVID vaccination, we very quickly realized we do need to generate some local research. And I think, to echo what Dr. Monze talked about, it's very important for those of us in research institutions and running research programs to ensure that we are ever ready to adapt our research work into some productive utilization of what is currently pertaining. Because if you will wait for when you will win a grant, I think that time might pass you by. So at SIDE, as we very quickly began to look at seroprevalence of SARS-CoV-2 really early on in the outbreak, to try and see, based on the samples that we had obtained from cohorts of health workers whom we had been following for hepatitis B infection. So we had samples for the time that was before the COVID outbreak in Zambia and after the COVID outbreak. So we very quickly developed a home-based assay which we used to generate the results to demonstrate exposure to COVID-19. And we wanted to confirm whether children, because there was a lot of myths and misconceptions around children, whether children have been affected as well. So we equally had access to samples from children from before the outbreak and after the outbreak. And so this graph here basically confirmed for us that we were able to see almost equal exposure in children as in health workers, actually. And that was quite startling, and this work was done by a PhD student who should be completing her graduation later this year. But basically to show that children were also at risk, and they were already getting exposed to COVID infections. Then one more piece of work after we began the vaccination program, we wanted to really demonstrate the safety and immunogenicity of the vaccines that we are using within country. And again, these are not funded research programs. These are internal research programs that we generated research questions, mobilized reagents, mobilized teams, and basically began to get on with the assays. And we did look at up to 263 individuals. These are all adults, because at that point, only those above 18 were receiving COVID vaccination. And so we generated assays that would use to evaluate the immune response to the various vaccine antigen targets, specifically for AstraZeneca vaccine, for Sinopharm vaccine, for Pfizer, and for J&J. And based on what vaccines individuals received, we then really looked at immune response, looking at a basic IgG response, and categorized those who would really meet the threshold for what we qualified as responders to vaccines and non-responders. And this table here is summarizing basically the responses that we got to the various categories of vaccines, and the very first one really being response to the wild type antigen, then to Delta and to Omicron, and then run this by individuals who received respective vaccines from before they received the vaccine up to, in this slide, up to the time they received the second dose of full vaccination. And then we followed these cohorts for up to 12 months. And in this slide, we are comparing really the responses from the first visit, that's before vaccination, to the very last visit after they've received vaccination, and in this case have received booster doses as well. And this is really a graphical representation of the immune responses. Seeing, I hope you can appreciate the colors there. I think the blue would relate to responses to the AstraZeneca vaccine. I got to step down. So the blue to AstraZeneca, the pink, is it? Yeah, pinkish red into Sinopharm, then Pfizer, green, and then J&J. Basically, what we are showing here is that we observed specific immune response in all these vaccine recipients that really showed that the Zambian population that received these vaccines were responding as expected with specific immune responses to those vaccines. And we observed also over time that there was suggestion of waning of responses for some vaccines, but stronger responses for others. And in concluding these brief findings, what we basically are able to say, and we are still looking and combing further into these vaccines so that we can plot them over time to hopefully be able to show when is an appropriate time for a booster dose by which vaccine in our population, and that analysis is right now ongoing. But the conclusion of all these pieces of work is really that, firstly, as we were battling the spread of SARS-CoV-2, we were able to quickly determine community transmission among children. And this was at a point when children were still considered as not being at risk of transmission, but the exposure that they had was comparable to that which we saw in healthcare workers, meaning they had as high a transmission as those who are deemed to be at increased risk. And secondly, that all vaccines that we used, at least within the data set that we collected, did not trigger any signal of safety, and they were well tolerated within the adult populations here in Zambia. The Pfizer recipients demonstrated particularly high immune responses against the wild-type antigen, and the vaccine response 1 month post-vaccination was really between 76.6 and 85% to the wild-type response, very high immune responses. The last point to make really is that the booster doses that individuals received ensured that we had sustained titers of IgG over time. The question is, how long is over time? And I think we heard about the advantages of hybrid exposure and immunization. So I like to believe that most of the individuals that have received these vaccines, many of us have also had exposure to the natural infection, and some of that natural infection is hopefully boosting our immune responses as we go. But I think we need to continue research to try and figure out at which point do we explicitly require to get booster doses, if that is the case, and be able to inform into our immunization program. The last thing I want to mention is that immunization program here in Zambia has since moved on from campaign mode to routinize COVID vaccine, access to COVID vaccination. And so any person wanting to get vaccinated simply has to go to facilities that are offering vaccines, and they will be vaccinated at any time as we go forward. Chair, I think this is my last slide. Thank you very much.